speaker because since I arrived at Cooper, she has not only been one of my favorite people to be around, but she's also one of the smartest people that I know in the hospital. And I have definitely used my lifeline with her, my phone a friend, many, many times. So thank you for all of that.
Well, no, I appreciate that, and that is something that is that's compliments exchanged by critical care surgery and EM that doesn't normally get exchanged. So you got just a lot cooler today,
well,
and
thank you.
I hope that I can stay in your cool book.
Oh, always, always. I got to say, one of the cool things about our hospital is the relationship between trauma surgery and critical care and emergency medicine. Everyone just seems to play nice.
So, spoiler alert, I'm actually going to mention that in my second talk today, but
okay.
I'm really glad to know that I'm not the only one who feels that way.
Fantastic. So without further ado, I'm going to hand it over to Dr. Selena Wido, who's talking about the last straw.
Thanks, everybody, for the opportunity to be here today. This is a topic that is not necessarily new, not necessarily all that novel, but something that's really important because it continues to be debated regardless of the amount of literature that comes out. So full disclosure, I'll let you know a little bit about that I am a trauma surgeon. I'm an intensivist. I practice at a busy urban level 1 trauma center. So I'm going to have some biases. I've tried to be pretty aware of those, and we'll try to kind of mention when things are my opinion versus data-driven, but there is still a lot of surgeon in here that will probably come through when you hear me talk today. So when talking about pigtails versus open tube thoracostomy, the big fun procedure, the context really matters. It matters if it's traumatic versus non-traumatic etiology of the problem you're trying to solve. If you're trying to get out blood versus air, if you're taking care of adults, if you're taking care of children. There is obviously a big difference in who you're talking to. I think surgeons tend to be more apt to go ahead and put their fingers right in something because that's something that we're doing all the time, all day, every day. And I think that the folks who are on the front end of that are more apt to put in pigtails. There's a ton of selection bias in the literature that's out there. It is absolutely no secret that the vast majority of studies have not been done in a real randomized fashion. This is really up to the discretion of who falls into which treatment category. So the literature that we do have, the literature that we can talk about, is fraught with the sickest patients already got the chest tubes, and the people we perceive to be less sick are getting the pigtails. So that's really going to kind of change what we have to talk about. And then also, just for today, for the purpose of setting definitions, when I say large bore or small bore is going to be anything greater than 20 French. Those are typically going to be 28 to 40 French surgical chest tubes. Small bore is going to be used synonymously with anything smaller than 20 French. This is usually your 14-ish French pigtail catheters. So why make a change? One of the things that I've heard throughout my medical career and life is we've always done it this way. And that just does not fly as a reason to practice medicine or a reason to practice certain things within medicine. And the pigtail catheter is absolutely not a new concept. In the Journal for the Society of Laparoscopic Surgeons in 1999, this was kind of one of the foremost papers that really started pushing us in the direction of pigtail pleural, like less invasive drainage versus tube thoracostomy. You got to give it to the laparoscopic surgeons. They're always pushing us to do things less invasively. Again, coming back to my bias as a trauma surgeon, I literally try to do things as maximally invasively as possible because that's what I love and enjoy. But I also understand that that is not the best thing for the patients on a consistent basis. So what else happened in 1999? Shakespeare in Love won Best Picture. Bill Clinton was impeached. And the Dreamcast was released for purchase in the United States. So needless to say, 1999 was a long time ago. We've been talking about this for a while. It's taken a while to convert the skeptics. Part of the debate that I continue to see regarding the pigtail proponents versus the surgical tube supporters is that the pigtail is less painful, that there's a lot of perception that it's easier, that there's less risk of recurrent pneumothorax at chest tube pull. And of course, the surgical tube supporters believe pretty much all of the opposite, that pain is fine, it doesn't matter. If you pull a chest tube correctly, you're not going to get a recurrent pneumo. That is false. And then we're back to what's the data going to tell us? We have to make sure that the intervention we're doing is going to treat the underlying problem. So surgical tubes, we know are going to evacuate blood and air. We need to know that pigtails are going to do the same thing. When it comes to complications, we know that there are some pretty big downsides to any sort of thoracic intervention. So we need to know what those outcomes are going to be. Surgical site infection, whether that be a skin infection or a deep tissue infection in the chest, those are thought to be more common with actual surgical tube thoracostomy more so than pigtail. When it comes to injury to parenchyma or lung, in a lot of series, it's been demonstrated to be higher with pigtail. When it comes to malposition, functionality of tube, or bleeding complications, literature's pretty mixed. You can pretty much kind of take your pick of pigtail versus tube thoracostomy depending on what you want to read. But you have to know, is the tube I'm putting in going to achieve the goal I'm setting out to do? And what kind of outcomes am I looking at in this patient's care? So when it came to not just talking about this for surgical management, status post hiatal hernia repair, et cetera, of pneumothoraces, we started talking about this for trauma. One of the papers that really kicked off the discussion was in J-Trauma in 2011. This was long enough ago that J-Trauma was still J-Trauma, not J-Tax. And this was a 2-year experience of pigtail catheters to treat traumatic pneumothorax. What they ended up finding was 90% of these pigtails were placed for simple pneumothorax, and they found no difference in the number of tube days, requirement for mechanical ventilation, insertion-related complications, and tube failure was 11% in the percutaneous group and 4% in the tube thoracostomy group, but this had a p-value of only 0.06. The authors made special note of this because while not statistically significant, it sort of is right there on the line that we generally consider, and they kind of called for a randomized control trial to be done prospectively to assess this difference. Wouldn't it be nice? So around the exact same time, now this is 2012, J-Trauma actually had just become J-Tax. And this group from a little tiny trauma center you may have heard of in LA County said, wait, we're still using big tubes. We're not convinced that the drainage of blood or fluid from a pigtail is going to be acceptable. We're not even convinced that people should be consistently using 28 French chest tubes. So what they did was they looked at tube thoracostomy, compared 28 to 32 French tube thoracostomy versus 36 to 40. So no pigtails in this study. But what they did was they found that there was no statistically different rates of volume of blood drained, pneumonia, empyema, retained hemothorax, unresolved pneumothorax, et cetera. So pretty much concluded that the smaller tube thoracostomy was not inferior to the larger tube thoracostomy. So this was pretty exciting because this is a great start. If we can use smaller tube thoracostomy, how small can we go? Can we start draining fluid using pigtails? So around the exact same time, it was later that same year, this is, if you notice, the authors were actually the same as the group who originally published in 2011 about the use of pigtail catheters for pneumothoraces. Now they're looking at 14 gauge catheters in blood on trauma patients. They ended up finding that the initial amount of blood drained from the chest was pretty much equivalent in the pigtail group and in the surgical chest tube group. So non-inferior. Then we have a couple years later, 2016, Journal of Thoracic Diseases. This was an expert consensus. There was no new data gained, no new patient investigation on this, but a group of thoracic surgeons were putting together everything that had been out before them and said, what is the changing opinion in management? What they came to the conclusion, the expert consensus here was chest tubes should still be put in for active hemothoraces or empyemas, and then they were a lot less strict in their recommendations on pigtails for other things. So in 2017, an injury, small tube thoracostomy, this is 20 to 22 French, an emergent management of chest trauma. So again, supporting the use of small bore tubes, not being inferior. And then this was in World Journal of Surgery 2016, a prospective study, 7 years using percutaneous 14 French pigtail catheters for traumatic hemo-pneumo at a level 1 trauma center. And through 7 years of their data, a relatively large N, they found that really the outcomes were not going to be substantially different in the group. So again, continuing to support the idea that pigtail usage is very much acceptable and adequate. So I think we hopefully have converted just about everyone over to the mindset that yes, there is absolutely a time and a place for pigtails. Yes, they are absolutely efficacious. And the kind of, we're just trying to figure out exactly some of the fine points within that space. So my friends at East actually got together a large group of trauma emergency medicine folks, and they came up with a practice management guideline. And this is management of simple and retained hemothorax. They had 4 separate questions they asked in this study, and the one that's most relevant to us was whether or not pigtail versus tube thoracostomy was recommended for the initial management. So for initial management of simple pneumothorax and hemothorax, they gave a conditional recommendation that pigtail is actually going to be your procedure of choice. That's wonderful news for the patients who do not want to be having surgical chest tubes placed. Bad news for a lot of our trainees who love to place surgical chest tubes, but they'll learn somehow. We got to do the right thing for the patient. One of the things that I want to just make mention of that the authors of this review, they did not find any specific high quality evidence to support the recommendation. They noted that specifically that all of the evidence was low quality. There was a lot of heterogeneity in studies. Some of the studies they reviewed had repeated data sets. They were at the same institution over the same period of time, reporting similar but different findings. And that at least 4 of the authors sort of recused themselves from making any recommendation at all whatsoever, probably due to the quality of the evidence. So conditional recommendation, pigtail's tube of choice for simple hemothorax, simple pneumothorax. It gets much more complicated when we start to talk about the folks who have already failed chest tube placement. So here's where I think the controversy still resides. I think we have put to bed the controversy of whether or not pigtails are adequate for drainage of hemopneumothoraces. Yes, they absolutely are. Where we're going to get a little bit more complicated, a little more granular, is penetrating trauma. Concern for risk of infection, contamination of the chest already exists. Concern for massive ongoing blood loss. If that blood clots, there are some series that demonstrate that the pigtail did clot more often than the surgical chest tube, though it was not statistically significant. You will find a lot of people still very much advocate for penetrating trauma with large loss. They should be getting a surgical chest tube. People with big air leaks. Now, this is not necessarily trauma patients, but there's a fair overlap here. People with big air leaks from bronchopleural injuries. They may be folks who have volutrauma, barotrauma from ARDS, vent management, from bad bleb disease. But people with big air leaks who are also receiving positive pressure ventilation probably should get a surgical chest tube or a larger bore chest tube or more than one chest tube, because the potential ramifications of clotting or occluding said chest tube can be catastrophic. The only thing worse than a tension pneumothorax is having a tension pneumothorax that occurs when you already have what you think is a functioning chest tube. And kind of the other big one is people who fail pigtails. Do they need a different intervention? Do they get a second pigtail? Do they get a tube thoracostomy? Do they end up going to the operating room and having resections, VATs, etc.? And there is a lot of this that has not yet been well defined. So I think the take home really is we have put this to rest. Chest tubes absolutely indicated for patients. Pigtails indicated most of the time. Procedure of choice in simple pneumothoraces, simple hemothoraces. There's still a lot to be said about the long-term management of the patients when they're in the hospital, tubes that are managing complications that have already arisen, failure of tube. But please feel free to put pigtails in as much as you want, because despite the surgeon in me loving and preferring tube thoracostomy from the, hey, it's fun as a doctor aspect, I very much appreciate what it's been doing for our patients, the amount of comfort it's been able to bring them.